Welcome to today's webinar, Medical Management of HIV Among Transgender Adults. I would like to introduce Dr. Tonia Poteat, Assistant Professor in Social Medicine at the University of North Carolina at Chapel Hill, North Carolina. Welcome, Dr. Poteat.
Thank you very much. I'm very excited to join you all this afternoon to talk about a subject that's near and dear to my heart. I want to start with some sort of housekeeping information that you can see on the slide. Having completed the webinar check-in form, you no longer need to type your full name and institution into the chat box to ensure that your evaluation form will be activated. However, I did notice some familiar names, so I was excited to see that you did type your names there so that I know you're on the line. So a big shout out to friends and colleagues across the nation. And this is just a reminder that you must be pre-registered in order to be eligible to claim credits or to get a certificate. That's on the next slide. If you haven't previously logged into the new website, you will need to use your email address to reset your password. And the IAS-USA designates this activity for a maximum of 1.25 CME credits and also 1.25 nursing credits and pharmacy credits. Evaluations will be mailed to your IAS-USA My Activities page by 5 p.m. Pacific time today. And we are grateful for generous support for this activity from the sponsors that are listed on this page. Navigating the webinar is pretty straightforward. When there is a poll question, a separate window will pop up to show that question. You choose your response from the poll, not from the chat box. And after the poll closes, the responses will be displayed. If you'd like to ask questions, please type those into the chat box and I will answer them at the end of the webinar. And if I'm good at paying attention, I will try to answer them as we go along. So the first poll question, from which geographic region are you viewing this webinar? Okay. Looks like people are from all over. That's very exciting to see. The next poll question is, when the evaluation for this webinar is over, in order to claim your CME credits or other credits, when will it be available, the evaluation be available on the My Activities page in your IAS-USA account? I love the choices. Immediately after the webinar, by 5 p.m. Pacific time today, or when the moon hits your eye like a big pizza pie. Great, most of you are paying attention, so that's great, by 5 p.m. today. And then the final poll before we get started with the content is to please rate your level of experience in the medical management of HIV, with 1 being a novice and 5 being an expert. Okay, it looks like we have a spread of people, with most people being somewhere between 3 and 5, but some people newer to HIV care. That's great. Okay, and now I'd just like to open with some financial disclosures. I've received research support from Gilead Sciences and Deep Healthcare. And then to just dive in terms of the learning objectives. I hope that by the end of our hour or so here together, you'll be able to list common gender-affirming medical interventions, to summarize recent data on drug interactions between gender-affirming hormone therapy and antiretroviral agents, and describe the best practices for medical monitoring of transgender people with HIV on hormone therapy. And I'll say I did my best to provide information on trans women and trans men and gender non-binary people, but the information available is in that decreasing order. Most information on HIV among trans women, less on trans men, and almost nothing on gender non-binary people. So if you notice that disparity in the content of what I talk about, it's because of the evidence base that we currently have available. Okay. I want to start with the 2 pretest questions. The first is, recommended regimens for gender-affirming hormone therapy for transgender women in the United States typically include which one of the following regimens? Estrogen alone, progesterone alone, estrogen plus progesterone plus an androgen blocker, or an androgen blocker plus estrogen. Okay, great. It looks like most of you have some knowledge and experience in providing trans healthcare. And then there's one more pretest question. Emerging data on the poll. I'm trying to find out where I can read it. Okay. Emerging data. Let's see if I can move it in my. It looks like all of you can read it. Thank you. Emerging data on drug-drug interactions between tenofovir for pre-exposure prophylaxis and estrogen for gender-affirming hormone therapy suggests which one of the following? Tenofovir increases estradiol levels, tenofovir has no effect on estradiol levels, and tenofovir decreases estradiol levels. Okay. Good. Looks like some folks have some information on drug-drug interactions already, and some folks will learn some new information today. So that's awesome. So let's dive in. I'd like to start with definitions. Anybody that's heard me talk before has probably seen these slides, but I like to review them just to make sure that we're on the same page when I use terminology and you understand what I mean. The word transgender is often used to describe people whose gender identity differs from the sex assigned to them at birth on their original birth certificate. I use trans women to refer to people who have a feminine or female current identity, and trans men to refer to people who have a current masculine or male identity. There are a growing number of gender non-binary individuals who identify as neither entirely male nor female, or as a combination of male and female. And cisgender is a word that's used to describe people whose gender identity is the same as their assigned sex at birth. We have data from the Behavioral Risk Factors Surveillance Survey on the number of people in the United States who identify as transgender, and that's about 1.4 million people, representing 0.6% of adults in the United States. And you can see from the graph here that people who are younger are more likely to identify as transgender than people who are older. However, that is limited to people who identify as transgender. There are people who fit the definition that I provided for trans or transgender who may not self-identify as transgender. And capturing that data is also important. So what you see on this slide is the recommendations from the Center of Excellence for Transgender Health on how you might ask about gender identity in your clinical practice and in research. The first step is to ask about someone's current identity and to offer many options, including just man or woman or male or female, because not all trans people feel like they need the trans label in front of their current gender identity, as well as trans options, genderqueer options, and other things that might be relevant for the region where you practice. And the second is the sex assigned at birth on the original birth certificate. On the right-hand side of the slide, what you'll see is data from the CDC's HIV testing event data. And when they used just the one-step question, the first question, what is your gender identity, and provided a list of options, they identified about 12,000 people in the data set as transgender. However, when they used a two-step model and were able to identify people whose sex assigned at birth was different from their current gender identity, even if they did not select one of the transgender options as their current identity, you can see that the number of people identifying as transgender almost doubled. So it really makes a big difference in terms of how you count. We have new data on the prevalence of HIV among transgender people in the United States. This was published towards the end of last year by the Centers for Disease Control and Prevention in an article in the American Journal of Public Health. They looked at data from 2006 to 2017, a total of 88 studies, both from their internal CDC data sets as well as published peer-reviewed literature. And they identified 9.2% as the estimate of HIV prevalence among transgender populations at large, with, as you can see, differences between trans women and trans men, with 14% prevalence among trans women and 3.2% among trans men. And we see in the data that we typically see higher prevalence of HIV among trans women compared to trans men. They also looked at risk behaviors related to HIV and noticed that there was a high prevalence of sex work among both trans women and trans men, and low levels of PrEP knowledge, with even lower knowledge among trans men compared to trans women. They also broke down the data by race, and you can see, similar to how we see dramatic disparities in HIV prevalence among by racial groups among the general population, we also see dramatic differences in HIV prevalence among transgender women in the United States, with 44% estimated prevalence among Black transgender women, almost 26% among Latinas, and lower among whites and other racial groups. So now I want to dive into talking about the HIV care continuum and how we engage, what we know about trans people and their engagement in the HIV care continuum, and talk a little bit about what we can do as healthcare providers to improve and invite people to engage in the HIV care continuum. I'm actually going to start at the end because our ultimate goal is to help people achieve viral suppression for their own health and for prevention of onward transmission. I'm going to start with the largest data set of trans people living with HIV in the United States is from the Ryan White HIV/AIDS program. They're the largest provider of HIV care services in the United States and have a data set of their most recent data set included over 9,000 transgender individuals. And you can see the racial breakdown and the gender breakdown listed here. When they compared viral suppression rates among the cisgender men, the cisgender women, and all transgender participants, you can see that the transgender participants had a significantly lower level of viral suppression compared to the cisgender participants in the Ryan White program. I don't have a slide on this, but when we looked within the transgender population, we also saw disparities by age and disparities by housing stability. So all of the factors that impact engagement in HIV care and viral suppression in the general population also further reduce viral suppression in transgender population. So the next question that I ask when I see disparities like this is why? And we have some data from research that's been done within the community, and I wanted to start with that. This data that you see at the top is from the Positively Trans Project, which is a research study that was conducted by the Transgender Law Project. They conducted a survey with over 400 transgender people, regardless of identity, trans men, women, non-binary people, living with HIV, and they had usable data among about 157 of those participants. One of the questions they ask is, what are your top 5 health priorities? And these are trans people living with HIV. And you can see the top 2 priorities were gender-affirming and non-discriminatory care and hormone therapy and its effects. The 5th of the top 5 priorities was antiretroviral therapy. And this is a reminder to us that people will often prioritize living authentically and accessing gender affirmation before they prioritize antiretroviral therapy and HIV care. And so that suggests that bundling those things, ensuring people have access to both, is one way that we can improve engagement and care. And this is supported by baseline data from HRSA Special Projects of National Significance that was conducted to improve engagement of transgender women of color in care. So there were 9 STEM sites across the United States, and they were provided with funding to implement programs to improve engagement. They have completed these projects, and I think the data is currently being written up, and we hope to see it published soon. But from the baseline, we knew of the 400 participants that provided baseline data. For those whose HIV primary care provider was also their hormone prescriber, they were more likely to have had an HIV primary care visit in the prior 6 months, so be engaged in care, and also more likely to have an undetectable viral load, suggesting again that bundling these services together in a gender-affirming way helps improve engagement in care and viral suppression. Going back to the data from the Positively Trans survey and getting more granular beyond sort of the services provided, but to the interactions between the providers and transgender patients, they asked a series of questions about provider attitudes and its impact, and looked at its impact on self-reported viral suppression. I think the key things to notice here is that if someone reported that their provider of HIV care was neutral or hostile towards their gender identity, they were less likely to achieve viral suppression. And I think what's important here is hostility obviously is going to be a deterrent to people, but even being neutral was a deterrent. People actually needed, it suggests that people actually need affirmation of their gender. And then the second thing to notice is that providers who restricted access to hormone therapy based on someone's compliance or adherence to the antiretroviral therapy, those participants were reported lower levels of viral suppression as well, also suggesting that using someone's access to hormone therapy as a stick to try to make them more adherent to antiretroviral therapy is not an effective approach. So I've talked about gender affirmation and talked about gender-affirming care, but I haven't defined it yet, so I want to take a moment to do that. Gender affirmation is any of the processes that a transgender or gender nonconforming person may use to affirm a gender identity that's different from what's assigned at birth. For many people, this is a deeply spiritual experience as well as a psychological experience. It's a social experience, and we're going to talk a little bit about how people socially affirm their gender. Can be a legal experience for some people who change their name and gender markers, and also can be a medical experience for people who seek gender-affirming hormone therapy or surgeries. Some of the ways that people might socially transition or socially affirm their gender, in addition to using what we might call a nickname or pronouns that were different from the pronouns that might have been used when they were born, are through interventions like binding, tucking, and using soft tissue fillers. And these all have implications for health. I just want to spend a quick moment talking through them briefly. For people who seek to masculinize their chest appearance, binding is often a way to do that. People can use professional binders, like you see pictured here in the far left, that you can buy online. But they might also use sports bras or double sports bras or ace wraps to flatten the chest appearance to make it more masculine. This is important because there's been some early studies looking at the health consequences of binding, and people might have issues with skin integrity, issues with breathing, musculoskeletal symptoms related to binding, and it's important to assess that in our patients. In the middle is sort of a cartoon of tucking, and this is something that's done to create a flat appearance to the front of the pant or skirt area. So the testicles are tucked up into the pelvic cavity and the penis tucked in between the legs. And held in place sometimes by something called a gaff, or sometimes by duct tape, or sometimes by underwear, tight underwear. This also might have implications for skin integrity and potential implications for fertility if somebody desires that in the future. So it's also another important thing to assess. And urinary complications are also potential. issues. There's much less data on the health impact of tucking. And then finally on the right, you see a CT scan of somebody who's had soft tissue filler injections in their breast. And soft tissue filler injections are common, especially in urban areas. People often call them silicone injections. They may or may not be silicone. They may or may not be medical grade silicone. They are never on label. And people use them to rapidly accelerate typically feminization. So they get injections in their breasts, hips, buttocks, and sometimes their face to feminize. These are not, it's usually not legal and not done by a licensed medical provider. And there are significant health consequences associated with soft tissue filler use, including inflammation, migration of the filler throughout the body, infection, and there have been reported cases of acute respiratory distress syndrome related to soft tissue filler use. So I always assess with patients whether or not they're using fillers and then try to provide some education around that. In terms of medical and surgical gender affirmation, you can see from this page there are many different things that people can do to medically affirm their gender. Feminizing interventions are listed on the left, and masculinizing interventions are listed on the right. So on the left, you can see that the top two are hormonal interventions, estrogen and androgen blockers. You had a pre-test question about that, followed by a series of different surgeries that people may undergo, may or may not undergo to affirm their gender. And on the right, you see testosterone is a hormone intervention, and below that are a series of surgeries that people may or may not undergo to affirm their gender. And I like to list these because sometimes people will ask a patient if they've had sex reassignment surgery or gender-affirming surgery, and it's really important to be more specific than that and find out what actually, if a person has had surgery, what surgery they actually have had, so that you have your awareness of their appropriate anatomy. I put estrogen, androgen blockers, and testosterone in blue because that's what we're going to be focusing on for this particular webinar. I also like to put up front that there are access to clinical guidelines that will provide much more detail than I'm able to provide in the brief webinar today. On the far left is the Endocrine Society guidelines. Those were last updated in 2017, and those are available in the peer-reviewed literature. In the middle is the World Professional Association of Transgender Health. They publish regular updates to their guidelines. Their most recent guidelines or standards of care were published in 2011, but they are actively gathering evidence and writing the Standards of Care 8 that expect to be released either later this year or early next year. And then on the far right is the Center of Excellence for Transgender Health at the University of California, San Francisco, that has online, freely available, evidence-informed guidelines that were last updated in 2016. So let's dive into the more details through a case. And this case is Brittany, not real name of the patient. 22-year-old trans woman with congenital HIV, so born with HIV. She presents as a new patient to your office requesting hormone therapy. Her past medical history is significant for recurrent fluconazole-resistant thrush. She hasn't taken any antiretrovirals for the past year and doesn't remember what prior regimen she was on. She moved in with her boyfriend last year, and she's currently unemployed. Her labs were last done 6 months ago, and her CD4 count was 120, and her viral load was 80,000. Her CBC and CMP were unremarkable, and she has no resistance or mutations on her HIV genotype. On physical exam, you notice that she has bilateral breast buds, a waist-hip ratio of 0.7. Otherwise, her exam is unremarkable. So for Brittany, what do you need to meet her needs today? Does she need the same history, physical, and labs as other HIV patients as you think about her request for gender-affirming hormone therapy? Does she need additional history but the same physical exam and labs, additional history and labs but the same physical exam, or additional history, physical exam, and labs are needed? Great. It looks like most people think she needs additional history, physical exam, and lab, and I would agree with that. In terms of medical history and labs, the most important difference is going to be from your other HIV patients is that you want to document her gender history. You want to know what kind of social gender affirmation she's engaged in. Is there tucking, binding? What name does she go by? Pronouns. Hopefully you would have all that before the person came in terms of choice of name and pronouns. But definitely asking about tucking and other gender affirming interventions. Binding would be for transmasculine individuals. Ask about hormone use, whether prescribed or not prescribed, the dose, the duration, if she's been on and off, where she might have gotten it from, and if she's aware of the names. That's also very helpful. You want to know if she's used needles for hormone injections or for silicone injections or other fillers, and if so, if those needles have been used by others before or after her, looking at HIV and other infection transmission risks. You want to know if she's had any gender-affirming surgeries and what those were and when she had them. And to document any gender document changes. So has she had or does she desire changes to her gender marker? For example, on her passport or on her driver's license, does she desire a legal name change, or has she had that? Important to that is going to be to understand her gender-related goals. Not everybody wants the same thing out of gender-affirming hormone therapy. So finding out what those are in terms of physical changes as well as legal changes and social changes. And addressing psychosocial issues are going to be important as they are for all of our HIV patients, but particularly there are high rates of depression, PTSD, substance use in trans communities, so you want to find out what her experience of those things might be and what her risk factors for those things might be. We also know there's high rates of unemployment and sex work and a lot of violence against transgender communities, so assessing her safety, her access to social support is going to be important. In terms of baseline laboratory tests, they would be very similar to what you get for your other patients living with HIV, but also baseline testosterone would be very helpful so that you can follow that in terms of monitoring her on hormone therapy, and we'll talk more about that a little bit later, and a baseline estradiol level. I put a question mark in front of the prolactin because most of the providers I know don't get a prolactin level, and I don't typically get it. We usually check it if someone is having symptoms of a prolactinoma, but there are some people who make it a routine practice to check it at baseline. In terms of sexual history, this is important for all of our patients living with HIV, but for trans patients, it's going to be especially important to avoid making assumptions, even assumptions we don't realize we're making. So when we ask about sexual history, it's important to think about ways we can ask about it without assuming the gender or sexual parts of the person they're having sex with, or even what kind of sexual activity somebody's engaging in. And this can be useful actually for any patient. I know I was trained 1,000 years ago to ask if someone was having sex with men, women, or both, and that's actually not so helpful a question in 2019. Some questions that I have used are, how many partners have you had in the last 3 months? What are the genders of your partners? Tell me about the kinds of sex that you're having. Asking about exposure to other people's fluids or exposing others to their body fluids. Asking how someone protects themselves from sexually transmitted infections, how they protect their partners, if they use barriers and how often. Asking about the times they do and don't. All those things to try to open up a dialogue so that the person can really share with you what their sexual history is like, and you can help them understand how to protect themselves and protect their partners. In terms of the physical exam, I always expect that most patients living with HIV have had some negative healthcare experiences just because there's so much stigma. But there's also stigma, especially specific stigma, against transgender people. And healthcare-related stigma against transgender people is unfortunately pretty high. In the U.S. trans survey that was conducted in 2015, there was 27,000 transgender people who completed that survey, and the vast majority of them reported concerns about healthcare providers not being adequately prepared to provide care for them, and they reported being mistreated by healthcare providers. One of the ways that I try to address that is to use trauma-informed approaches, not to do any physical exam elements that are not essential, especially if I haven't established rapport with the patient yet, to let them know the reasons for any physical exam I'm going to be doing. Like if I'm going to listen to your lungs, what am I listening for and why am I doing that? If I need to do a genital exam, why am I doing that and what am I looking for? Being consistent with correct pronouns and names and gender markers is really important. And when doing the physical exam, it's helpful to do an anatomical inventory in advance. This prevents surprise, so you know what to expect in terms of what anatomy will be present. And it's important to identify, screen, and treat the body parts that are present for that person. And I provided a couple of examples of things that might be unexpected for providers who don't have a lot of experience in transgender healthcare. So on the left, there's a picture of someone who is post-vaginoplasty. And you can see to the far left, there's the rectum, and in the middle is the neovagina, and no, that's to the right. No, my left or my right. So the far right is the rectum, and the middle is the neovagina, and to the left is the bladder. And this is important because the prostate is not removed typically during vaginoplasty. So if you're going to do a prostate exam, which will be particularly important for transgender patients, and we'll talk about that in a little bit, it may be helpful to do it through the vagina, not a rectal exam. On the far right is a transmasculine person who's had metoidoplasty, and that person, and people often call this a clitoral release surgery, so it's not a phalloplasty, but it's more of an extension of the urethra to create a smaller penis. You can have metoidoplasty without having a vaginectomy. So this person has both a vagina and a neophallus, and it's important to consider that that person may still need cervical exams if they still have a cervix. So those types of things. So being really careful about understanding what has been done and what hasn't been done, what anatomy remains, and what needs to be examined and screened. So let's dive into hormone regimens. I'll start with feminizing regimens. You'll notice in bright yellow, estrogen plus anti-androgens are typically the regimens that are used for feminization in the United States. I won't go through this slide in a lot of detail, but you can see the doses, the starting doses, average doses, and the maximum daily doses that are recommended based on the Endocrine Society guidelines. I will note that spironolactone is what's most often used as an anti-androgen. It is a fairly old potassium-sparing diuretic, so there are some issues in terms of monitoring that you need to do for someone on spironolactone. It's also very inexpensive and helpful to use. If someone can't use that, you can see some of the other options that are available. We use the anti-androgen in order to allow for feminization at lower doses of estrogen in order to try to prevent some of the concerns around high estrogen doses. 17-beta estradiol is the type of estradiol that's used. You can see Valerate or is available orally. There's injectable estradiol. The doses vary depending on which type of estradiol you're using. For folks who are at high risk for clots and cardiovascular disease, providers will often use patches, especially if somebody's a smoker and they're over 45. What are not recommended are ethinyl estradiol, which is the type of estrogen that's in oral contraceptive pills. They've been associated with higher risk of clots. And conjugated equine estrogen that's often under the brand name Premarin is not recommended. You may see people who are already on Premarin from other providers or who get Premarin from non-medical or informal sources, and it's important to talk about the elevated risk of clots with those medications. I put just a little note here that if somebody has had an orchiectomy, if they've had their testicles removed, that they no longer need an anti-androgen. The expected effects of feminizing hormones are redistribution of body fat, moving more from an apple shape to more of a pear shape. We see decreases in muscle mass, softening of the skin, decreased oiliness of the skin, decreased libido, decreased spontaneous erections. People can often still get aroused and have erections, but those often have decreased tumescence. And that can be an issue for trans women who still desire penetrative sex, to be the penetrator during penetrative sex. Breast growth is common expectation and expected effect of feminizing therapies. We also see decreased testicular volume, decreased sperm production, decreased terminal hair growth. Decreased testicular volume and sperm production does not necessarily prevent pregnancy, but certainly reduces someone's fertility. So having conversations with people before they start hormone therapy is important if they desire to have biologically related children. And decreased terminal hair growth is often related to what we call male pattern hair baldness. So starting hormone therapy will not reverse male pattern baldness, but it can slow it down or stop it. The things that we worry about in terms of potential adverse effects from estrogens, you can see in bright blue there, I put venous thrombosis and pulmonary emboli. Those are really our largest concerns. And that's the reason for recommending certain types of estrogen and for trying to use lower doses whenever possible through the addition of anti-androgens. Other less common concerns are hypertriglyceridemia, elevated blood pressure, gallbladder disease, and prolactinomas. For prolactin, we are mostly concerned about low blood pressure and hyperkalemia, so we recommend monitoring for that. I want to spend a couple of slides just diving into some specifics around cardiovascular health and bone health because we have a little bit of data around that now for transgender people. We do see, as I mentioned, increased rates of DVT and PE related to estrogen. This often occurs during the first year of hormone therapy, and there are usually other risk factors like smoking or HIV. I provide care only for people with HIV at this point, and so all of my patients are increased risk for DVT and PE, and I want to think through that when I'm talking with patients and making sure they understand the risk and benefits of estrogen therapy. And again, ethinyl estradiol is the highest risk estrogen to use, so avoiding oral contraceptives at all costs if possible. There is some data that estrogen use increases risk for cardiovascular disease, so not just blood clots, but ischemic disease. This data suggests an elevated risk of death from ischemic heart disease, especially if ethinyl estradiol is used, and as well as an increased risk of early fatal stroke. And these, unfortunately, most of this data is from European cohorts, but we're beginning to gather more data and data specific to people living with HIV in the United States. I'm hoping in a year or two, if we do an updated webinar, we'll have more data from trans women living with HIV in the United States. But for right now, the take-home message is to avoid ethinyl estradiol. I don't think that's going to change. And to have a high index of suspicion for DVTs and PEs, as well as cardiovascular disease for trans women who are on estrogens. This is not a contraindication to estrogen, but a recommendation that we monitor carefully and address risk factors. It's also important to note that cardiovascular disease risk calculators may underestimate risk. We know that they're not great risk calculators for people with HIV in general, and none of them have been validated in transgender people living with HIV. So again, encourage smoking cessation. That's the best thing one can do to reduce risk for cardiovascular disease among our patients, and consider transdermal patches for older smokers. In terms of bone health, there was a study that suggested that osteopenia was more prevalent at baseline when in a study that compared trans women with age-matched cisgender men. And you can see there that osteoporosis rates were higher as well as osteopenia. The greatest risk for osteopenia is after gonadectomy. So if someone's had an orchiectomy or a nephrectomy, and they don't replace with hormone therapy, then they have increased risk to their bones. There have been some studies on feminizing therapy, but they've been inconsistent. It does appear that trans men who are on testosterone maintain adequate bone mineral density. So the take home for this is to consider obtaining bone mineral density measurements when there are risk factors for osteoporosis in our patients, and to especially consider it in those who stop sex hormone therapy after gonadectomy, or if their ART regimen includes tenofovir. This may be changing as we have TAP and the suggestions that it has lower risk of bone impact. Let's go to another case. This is Rodney. Rodney is a 30-year-old gay trans man with newly diagnosed HIV that's here to initiate ART. His past medical history is unremarkable. He's had no history of surgery. His last menstrual period was 3 months ago. The CD4 count is 450 and viral load is 85,000. He has wild type on his genotype. His other labs are normal. His physical exam was normal, but the GU exam was deferred. And he takes testosterone 200 milligrams every 2 weeks. I'm going to ask you a question, provide a little information that gets back to that question. So, does Rodney need additional testing before starting ART? We saw that the labs that had been done and what was available. Great. It looks like most people said yes, he does need additional testing, and I will agree with them, and I will explain why. I'll first start by describing a common masculinizing hormone therapies. Most commonly, IM or sub-Q injections are used. It used to be that all the guidelines were for intramuscular injections, either cypionate or enanthate, and the doses are listed there. But we've gathered more and more information on using sub-Q injections, and it seems to be just as efficacious with a decrease in pain and decrease in scarring. So many practices are moving to sub-Q injections. Also, transdermal gel and transdermal patches are commonly used. Less commonly used are testosterone pellets, and these are pellets that are inserted subcutaneously under the skin, remain there for several months, and are removed and replaced. And sublingual testosterone I haven't seen used in the United States. Important thing to remember about masculinizing hormone therapy is that it is not a form of contraception. So Rodney would need a pregnancy test. His last menstrual period was 3 months ago. We don't have a sense of his GU exam, but we know he's had no gender-affirming surgeries. We know that he's a gay man and his partners are cis men. So we want to make sure that we understand whether or not Rodney is pregnant. Other expected effects are facial and body hair changes, deepening of the voice. Usually once someone starts testosterone, they reach amenorrhea in 6 to 12 months, but there's been a few recent studies that suggest that it could be longer in some people. If somebody has not achieved amenorrhea in 6 to 12 months on testosterone, you might want to consider whether the dosing is adequate. You commonly see clitoral enlargement, atrophic changes to the vagina, and reduced fertility, reduced but not eliminated fertility. Adverse effects include acne and oily skin. Those are the most common, sometimes migraines, weight gain, fluid retention, and polycythemia. Polycythemia is the reason that we want to follow hematocrit and hemoglobin over time. It's an expected effect of testosterone, but if the hematocrit gets too high, you might want to consider phlebotomy as a way to manage that, or reducing testosterone doses. Hepatotoxicity appears in the literature as a potential side effect, but all of the healthcare providers I've talked with, and I haven't found any data that really support the hepatotoxicity of injectable testosterone. I think most of the concerns around when oral testosterone was more available. And we do see some worsening of the lipid profile. So in brief, hormone therapy monitoring, typically we monitor for every 3 months in the first year and then move to every 6 to 12 months. In terms of monitoring the efficacy of hormone therapy for feminizing hormones, usually the goal is to have a serum testosterone level less than 55 nanograms per deciliter. And I say usually because we really try to adjust based on the patient's response, their clinical response, with giving them realistic expectations about how long things might take. I sometimes tell people that the first puberty took them 3 to 5 years, and this will be a different kind of puberty that typically takes as long to see the maximum level of results. So not that long to start seeing results, but that long to see the maximum level of results. We try to keep the serum estradiol peak at 200. Prolactin levels, as I mentioned, are not recommended unless someone is symptomatic. What is important is that PSA levels, blood levels, are not reliable in the presence of estrogen. So if you have a concern about prostate cancer in a patient, you're going to rely on your digital rectal exam, not PSA levels. For masculinizing hormones, for testosterone injections, the target level is about 400 to 700 nanograms per deciliter, and you want to measure that mid-cycle. If they're using IM or sub-Q injections, or 2 hours after application, at least 2 hours after application if they're using a transdermal daily dose. All the other monitoring that you will do will be per the HIV and USPTF guidelines. I see a question about why do you check the prolactin level. I don't check the prolactin level. The concern is if there is a prolactinomia that is estrogen responsive and you're giving someone estrogen, it might increase the size of the prolactinoma. But if somebody's asymptomatic, I don't typically check it. Is not most of the data on PE? Okay, great. So next question is not most of the data on DBT and PE in regards to ethinyl estradiol and not what we use in our actual patients. Actually, there is data on estradiol. So the studies that I was mentioning were studies in transgender women. Most of them are European studies, so they may or may not be using exactly the same estradiol that's available to us here, but it's not birth control pills or ethinyl estradiol. It is the estradiol that we use. Some people have requested injectable estrogen instead of oral, that it's more physiologic. Yeah, there's no data on injectables being more physiologic. I think that there are some myths around that in the community. The one benefit of an injectable versus an oral is that you avoid first pass through the liver, so if there's concerns about that. And somebody asked, is pregnancy test the only additional test that you would do for a rapid start? I think that referred to the slide with the transmasculine person, and yes, I would add a pregnancy test for rapid start as well. And then I'm going to get back to these other questions because I think there will be a lot of them and I might not finish. So hold on, I'll get back to that list in a second. I want to talk a little bit about interpreting sex-based lab values. So there are a number of lab values where the reference range differs based on sex. And so how do we think about interpreting those results for our transgender patients on hormone therapy? We want to think about what hormones they are on and how long they've been on them, and if they've had any surgical interventions like a gonadectomy. Dr. Jamie Feldman in Minnesota recommends the following sort of algorithm. If they've never been on hormones or never had a gonadectomy, then you use the sex assigned at birth. That seems pretty straightforward. If they've had a gonadectomy and they're stable on a consistent hormone regimen, use their affirmed gender. And what gets complicated is if they still have their natal gonads and they have had a short period of hormones or inconsistent use of hormones, then how do you, what reference ranges do you use? These are the recommendations from the UCSF Center of Excellence guidelines. They recommend obtaining reference ranges for both female and male norms, so you have those available to you. Those are often pre-printed on the lab reports, at least that we get. And then you base your interpretation on the current hormonal sex rather than the sex that's on the laboratory form. The sex that's on the laboratory form typically reflects whatever their legal sex is. So if somebody's had their gender markers changed, then it'll say their affirmed gender, and if they haven't, it'll say a different gender, and that may or may not have any relationship to their hormonal or gonadal configuration. You have to use your clinical judgment and base it on what you know about that patient. And in the table below, it lists selected laboratory results and how to interpret them based on whether they're a transgender woman or man and what the lower limit and upper limit should be. So for most, you'll see that the upper limit is the male value. For hematocrit and hemoglobin for transgender women, you want to use the female value as the lower limit because depending on how long they've been on hormones, the hematocrit and hemoglobin may shift, and you don't want to miss anemia, but you also don't want to assume someone has polycythemia if they don't. The one caveat being for hemoglobin and hematocrit for transgender men, you want to use the lower limit of normal as the male value if they're on testosterone, but you want to consider using the female lower limit if they are still menstruating regularly because you don't want to artificially call them anemic when they're not. They just simply have a hemoglobin that's consistent with monthly bleeding. And this would typically be for somebody who's not on testosterone or early on testosterone. What about these sex-based risk estimates? We talked a little bit about CVD risk. You want to consider the age of hormone initiation and the total length of exposure. The Center of Excellence recommends choosing either an estimate for their sex at birth, their affirmed gender, or an average of the two. I typically do both, And if one of them suggests an elevated risk for CVD, then I have that conversation with the patient, because I feel like our HIV patients are more likely to be at risk for cardiovascular disease, and transgender women on hormone therapy are more likely to be at risk for cardiovascular disease, so I want to err on the side of caution. For osteoporosis risk, the FRAX tool is one of the estimators that's available, and we know that bone mass is already attained for most people once they initiate hormones in adulthood, so the expert consensus is to use the sex at birth. And for renal impairment, for the estimated GFR, muscle mass changes are induced by hormone exposure, with increases for trans men in creatinine and decreases in trans women. So if you are concerned about somebody, if they're on the borderline of an intervention and you're not sure if you can trust the estimated GFR, then consider getting a cystatin C. So this is our last case. She's Marta. She's a 36-year-old trans woman who recently switched from an entity-based regimen to a boosted PI due to resistance mutations. And she's complaining of new hot flashes. Her CD4 count is 520. Her viral load is less than 50. Her other labs are normal. She has slightly elevated blood pressure. Otherwise, her exam is unremarkable. She's on TAF-FTC plus boosted darunavir. She takes 6 milligrams of estradiol a day and spironolactone 100 milligrams twice daily. So what is the potential most likely cause of Maria's hot flashes? Disseminated mycobacteria, early menopause, pheochromocytoma, or drug-drug interactions. Great. Most of you selected drug-drug interactions, and we're going to talk a little bit about what those might be. So drug-drug interactions are complicated. So I'm not going to go into the mechanisms of actions of how these drug-drug interactions happen. I'm going to go into what we believe we know about relationships between antiretroviral therapy and gender-affirming hormone therapy interactions. You see a table listed here that is drawn from the Department of Health and Human Services panel on antiretroviral guidelines for adults and adolescents. That is probably due to be updated soon, so you might see a different table in the coming months, but this is what's available now. And if we think back on Maria, we see that protease inhibitors may potentially decrease estradiol. So it's important to consider that she might be having symptoms of estrogen withdrawal, and to potentially check levels and consider adjusting her dose. I think a bigger concern, because I didn't go through this in a lot of detail, but estrogen in terms of antiretroviral therapy and the data we have, given that it's with oral contraceptive pills, no data for trans women living with HIV, very little data on trans women living with HIV who are on antiretroviral therapy and the drug-drug interactions with that type of estrogen. But for the oral contraceptive pills, we know that the oral contraceptive pills themselves are unlikely to affect the efficacy of combination antiretroviral therapy, but antiretroviral therapy agents may impact hormone levels. So in this cross-sectional survey of trans women in Los Angeles, almost 2/3 had used some type of hormone therapy, more than half were living with HIV. Of the trans women living with HIV, less than half had discussed hormone ART drug interactions with their provider, but 40% had not taken their hormones or their ART as prescribed due to concerns about drug interactions. So this is a big issue for our patients, and I think it's important for us to raise it and ask our patients and share the information that we have with them to provide some reassurance. Where we do see drug-drug interactions that have impact on efficacy of the drug is on PrEP, and I'm just going to walk through as quickly as I can some of the background of this. It's sort of rapidly changing over the last few years. So the IPREC study was a seminal study that was used for the approval of PrEP, and 14% of the participants were trans women. And in a secondary analysis of that data, they found a lack of efficacy of tenofovir for PrEP in the trans women in that study. It was important to note of the trans women who seroconverted, none of them had detectable tenofovir levels at the time of seroconversion, and no seroconversions were observed in trans women who had tenofovir levels consistent with taking at least 4 pills per week. So based on this, it wouldn't be surprising to think that adherence might play a big role in why we didn't see efficacy in an intent to treat analysis of this data. And I put here some of the adherence data from the FemPrep and Voice trials, which are 24 and 29%, very low adherence for cisgender women, and we see also very low adherence for trans women, and I think we need to address some of the barriers to adherence for women overall. But what I think was also intriguing and not necessarily explained by adherence was that for any of the participants in the IPREC study who were taking hormones, they had a drop in their tenofovir levels over the course of the study. And it raised the question, was there competing interest and people were less adherent because they were more focused on their hormone therapy, or was there a potential drug-drug interaction? And happily, several folks have started answering those questions. Data were presented at the International AIDS Society Conference in 2017 and then the R4P Conference in 2018. And I'll try to go over those relatively quickly, so we have lots of time for questions. Mackenzie Cottrell here at UNC did a study of hormones. She included HIV-positive people who were on tenofovir FTC regimens, including 4 trans women, 4 cis women, and 4 cis men. All the participants had an undetectable viral load, and all of the cis women were postmenopausal. And she conducted serum and rectal biopsies at one time point. And she measured serum estradiol and rectal NRTI concentrations. And to make a long story short, and you can read the paper because it's now been published in Clinical Infectious Diseases, the highest estradiol levels were seen in trans women, not surprisingly, and the highest testosterone levels in cis men. There was a reduction in rectal tenofovir among trans women, and tenofovir levels were lower, proportional to higher levels of estradiol and progesterone, suggesting that tenofovir has an impact on estradiol and progesterone levels. Another study that supported that was the IFAC study that was conducted in Thailand. It included 20 trans women who had not been on hormones for 6 months, and none had undergone orchiectomy. All were HIV negative. So this was specifically to look at PrEP. They were on a regimen that's common outside the U.S., estradiol and cyproterone. And you can see the graph here of when they started and stopped that medication in order to get levels. And also everybody was on the same regimen, so they could look at bidirectionality of interactions. So hormones impact on tenofovir and tenofovir's impact on hormones. And they did intensive PK assessment of estradiol, testosterone, and tenofovir. So the great news is that estradiol exposure was not affected by tenofovir for PrEP. However, there were lower plasma levels of tenofovir in the presence of hormone therapy. It was a 13% reduction, if I recall correctly, 13 to 30% reduction, but it wasn't clear if this was clinically significant. And finally, the data presented at the R4P conference in 2018 included 8 HIV-negative trans women on various hormone regimens, 8 HIV-negative cisgender men who are not taking hormones. And there was a required minimum plasma estradiol concentration for trans women to enroll in the study of 100 picograms per mil, just to make sure they were actually taking their estradiol, since the regimens themselves were not being controlled. Participants had directly observed therapy for PrEP on tenofovir FTC for 7 days, and their blood were drawn at frequent intervals, and a colon biopsy was done after 24 hours after the last dose. What they found, again, lower tenofovir FTC and their active analytes in the blood and rectal tissue in trans women. This reduction was consistent with a dose of approximately 5 doses a week, but keep in mind these were directly observed doses, so we know that the participants had 7 of 7 doses, but their levels were consistent with 5 of 7 doses. There was no impact on tenofovir FTC on estrogen levels. So again, that reassuring information and raising that question about drug interactions in the other direction. So again, we can share with our patients that PrEP does not lower hormone therapy levels in trans women, and that the jury's out on what it means that there's this slight lowering of PrEP levels in the presence of feminizing hormone therapy or estrogen. What I tend to tell my patients is that we know that PrEP works. We know that for the trans women who were on the IPREC study who were adherent, they did not seroconvert, right? So what it means is that we have less wiggle room in terms of adherence. That event-based dosing or missing doses is going to be less forgiving for someone who's on hormone therapy than someone who's. Unfortunately, there's very little data on PrEP for trans men, but just last month or I guess a month and a half ago now, there was some very preliminary data presented at the National HIV Prevention Conference. The researchers from UCSF presented data from the iBreathe study that included 24 HIV-negative trans women and trans men. They were stable on their hormone regimens, and they had directly observed PrEP via video calls for 4 weeks. They came in weekly for measurements of FTC, tenofovir, and the serum hormone levels are measured at enrollment and the last study visit. From what was presented, there was no identified impact of tenofovir FTC for PrEP on hormone levels, and analysis are ongoing to look at other parameters related to drug-drug interactions. So the CDC recommendations for PrEP have not changed. Its use should be considered for all persons at risk of acquiring HIV sexually. They report it's effective for anal sex after 7 days with a minimum adherence of 4 pills per week. I would say that we might want to increase that to 5 pills per week for trans women who are on estrogen therapy, and they recommend 20 days of daily use for all other sexual acts. So the take-home message for PrEP is that it's indicated for trans people at risk for HIV acquisition. Data are limited, but new data do suggest potential interactions, and also efficacy among trans women who adhere to the prescribed dosing. And best practices include destigmatizing gender-affirming approaches to PrEP engagement. And I just want to sort of close here towards the end with addressing a subject that's near and dear to my heart and that we all have complete control over in terms of our own behavior around stigma. We know that stigma is a barrier to engagement in all of its manifestations. And we can do our part to try to create as welcoming and affirming a clinic environment as possible. This includes using the names and pronouns that the patient wants us to use, not making assumptions about their gender identity or sexual orientation. If we're not sure what name or pronoun that patient wants us to use, asking them in a private, confidential setting when necessary, and including the name they want to be used and their pronouns on the medical record, and training all staff to use that information. Deferring unnecessary questions and exams just for the purpose of satisfying our curiosity, making sure we're able to describe to the patient the purpose of any exam that we're going to do, and do our best to build rapport before we do genital exams. If genital exams are necessary, always explain the purpose, use gender-neutral terms to refer to body parts, or ask patients what words they want you to use for their anatomy, and avoiding terms like pre-op or post-op unless you're actually discussing surgery. I have heard people refer to people as pre-op transgender or post-op transgender, trying to describe someone's anatomy, and actually that person may or may not have any interest whatsoever in surgery. And finally, I think the most important thing we can do is anticipate that we will have transgender patients, or that we already have transgender patients, and making sure that our education materials are appropriate and inclusive for trans people, that we have gender-affirming referrals and community resources. So if we need to send our patient to a cardiologist, doing our best to make sure we can send them to a cardiologist that will provide an affirming experience for them, and other community resources. Where possible, hiring transgender staff, making sure that people have access to gender-inclusive restrooms whenever possible. And if there are images of people in our office, including images of trans people, are signals, welcoming signals to our patients. I've listed some resources here, an implementation guide that's a global guide, the Center of Excellence for Trans Health, and the CDC has several initiatives related to transgender health and HIV. So we're back to the questions now. So post-test question number 1. Recommended regimens for gender-affirming hormone therapy for transgender women in the United States typically include which one of the following? Great. This looks great. Sounds like y'all stayed awake. I'm glad to hear it. So androgen blocker and estrogen is correct. And post-test question number 2, emerging data on drug interactions between tenofovir and for PrEP and estrogen for gender-affirming hormone therapy suggests which one of the following? Tenofovir increases estradiol, tenofovir has no effect on estradiol, and tenofovir decreases estradiol levels. Most of you got that right too. Tenofovir has no effect on estradiol levels. All of the data we have is in the other direction. It suggests interactions in the other direction, but tenofovir itself has no effect on estradiol levels from the data we have so far. Okay, I'd like to spend the next, I say 10 minutes responding to questions. I see that there's a bunch of things typed here in the chat box. And the first question I see is if they're on the antipsychotics, you check prolactin levels then. Again, I wouldn't want to be chasing a lab value because if the prolactin level is elevated but the person has no symptoms, then you might have just bought them all sorts of interventions that may or may not lead to anything that's helpful for them. So unless I had a concern based on symptoms, I don't usually check it. And the next, and that was the first two questions. I think the next one is for intersex clients. Do you recommend pelvic ultrasound to assist with anatomy inventory? That's a great question. For people with intersex conditions, if they don't have access to their own medical records and don't know what interventions they've had, then having some sort of imaging to help identify what organs are present can be very helpful. But I think for many people, accessing their medical records might be more informative. Hi, Mark A. Bear. How do you manage someone who refuses to quit smoking and on feminizing hormone therapy? I have many ad nauseum conversations, try to assist them with connecting to sort of quit lines and things like that. But if people absolutely refuse to quit smoking, then I talk to them about, if they're not already on a patch, switching to a patch. And I have to say, I will come out as a person who is, I guess, a risk taker as a healthcare provider. I think that people living their authentic self is priority for most people. We see that in the data. And we have some data that suggests that gender-affirming hormone therapy for people who need it is suicide prevention. So it's life-saving intervention. So I don't typically, it would take a lot for me to deny somebody hormone therapy. And I wouldn't do it because they were smoking. I would try to work with them around that. Any use for medroxyprogesterone? I don't use it in my practice. I don't usually use progesterone. Thanks for raising that. There are some people who swear by it. My experience has been that there isn't data to support its use for cycling. I think there was a time when people used to use it to help people cycle, and I call it like the PMS version of estrogen therapy, to like cycle on and off progesterone. And we used to think that it would help with maturation of breast tissue, and there isn't any data to support that as well. So given the concerns that are raised by the use of progesterone and its limited benefit to the patients, I don't typically use it. There are some patients who might insist upon it or come in already on it and not want to go off of it, but I don't start people on it. Do you measure estrogen levels in transgender men? Do you recommend any level ascertained? Consider risk of endometrial hyperplasia? Okay, multiple questions. I'll ask you at once. Great. I do not measure estrogen levels in trans men. And in fact, if you are on a bare bones budget and can only measure one hormone level, I would measure testosterone levels in everybody, right? So for trans women, you're trying to suppress testosterone to allow for feminization, and in transgender men, you're trying to provide testosterone to allow masculinization. So that is what I would follow. If I'm concerned about endometrial hyperplasia, there used to be this a lot of concern around polycystic ovary syndrome and trans men having PCOS, but what was discovered is that having a lot of cysts in your ovary is not the same thing as having polycystic ovarian syndrome, so there's less concern about that. I'm not sure how estrogen levels would help me in terms of thinking about endometrial hyperplasia. I might be more concerned about if they're having spotting or they start bleeding after they have been on testosterone for a while, then I might be concerned about endometrial hyperplasia and then intervene at that point. The next question, I'm a doctor from a developing country. Is there any training fellowship available in medical management of transgender persons? Actually, the Center of Excellence for Transgender Health has a sort of mini training program that's more about creating a welcoming environment. The guidelines are available online. I'm aware of one LGBT broadly training program at Callan-Lord Community Health Center. So you might want to reach out to them if you're able to come to the United States for a residency program. It's not a 2-year residency program. I think it's a several weeks or several months program for people to gain experience in this type of care, but that's the only one I'm aware of. Becca Cohn, what about PrEP? How do you counsel regarding how many weeks before fully active? 1 week for cis men, 3 weeks for cis women? Is it based on rectal versus vaginal sex or hormones play a role in? Great questions. I heard through the grapevine that the guidelines are going to be changing so that it's the same for everyone, but I haven't seen those guideline changes. So for now, I base it on the type of sexual activity. So if someone's having anal sex, then 7 days to full protection. And if they're having vaginal sex, then the 3 weeks for protection. That's how I provide advice. Because that's what the data is really about. The next question, perhaps TAF FTC PrEP levels will not be affected by HRT. That would be awesome. We actually don't have data with TAF, and given that how it behaves in the body is different, that might be true. So hopefully we'll have some studies to help support decision-making around that. How do you approach screening for GC chlamydia with a neovagina or with a phalloplasty? That's a great question. I typically ask people what parts they're using, and if they're using it, then I screen it. So if somebody's using their neovagina, a cervical screening might not be so helpful. Urine screening might be more useful. If somebody's had a phalloplasty, it depends on the type of phalloplasty they had. If they've had urethral extension through the phalloplasty, then you can check with urine. If they have a phalloplasty that's not connected to their genitals, if they have like an abdominal flap, then there isn't screening that's needed there. So hopefully that's helpful. Do you conduct a full physical on your new patients? Well, I'm supposed to conduct a full physical on my new patients, but trans or not, I tend to spend most of my first visit with patients getting to know them, building trust. And if there's somebody who came in and they're expecting their full physical, then they'll get a full physical. If there's somebody who's a little more hesitant, I try to build rapport and try to build in the genital parts of the exam into subsequent visits. Next question, is a neovagina susceptible to HIV infection? That is a great question, and I've only seen one teeny tiny study that was presented at CROI, not this year but last year, that looked at CD4 and CD8 cells in the neovagina and determined that it's different. But we don't actually know the susceptibility of the neovagina to HIV infection. More areas for research. Next question, I do not want to withhold gender-affirming care to patients with mental health history. Should I have any red flags or big concerns? That is a great question. We had our UNC HIV conference here yesterday, and Kristen Baker from Howard Brown did the sort of deep dive medical talk, and she works at a practice that's all LGBT and does a lot of gender-affirming care. And they have an informed consent model, and they also have access to behavioral health. So when somebody comes in for their first visit, they're usually able to start hormones that day because they have a behavioral health person who can come in and do a quick assessment if there's something someone's concerned about. And what she said yesterday that I think has been also true in my practice is rarely does somebody have a mental health history that would be a contraindication to gender-affirming care if they are able to provide informed consent. So if they have depression, it could be that their depression is related to lack of gender affirmation, and that would improve it. If they have something like schizophrenia, of course you want to make sure that their mental illness is managed, but there isn't any reason for that in and of itself to be a contraindication, unless someone is looking for hormone therapy to do things that it can't do. So the example she gave is if somebody came in for feminizing therapy because they wanted to have a baby, and that was part of their delusion. So it's important that people be able to provide informed consent for what will and will not happen when they're on hormone therapy. Yes, thank you, Josh. There is thank you for reminding me. I just got that email yesterday. There is a Trans Echo program from Fenway. So I think it's, if you Google the National LGBT Health Education Center, they have an ECHO program, which is a training program for health centers to become more gender affirming. You can, I think you can enroll in it from any place around the country. I'm not sure if it's available internationally, if people can enroll internationally, but that is definitely available. Thank you. In regards to PrEP, any tissue levels taken in transgender women in the neovagina? No, none of the studies that I presented to you and that I'm aware of took samples from people who had neovagina. Where there were tissue samples, they were rectal tissue samples. Anal and cervical paps are standard of care. What about screening for HPV in the neovagina? Yeah, that's an area where there's been no research done. I mean, I tried to do as evidence-based a talk as I could. I think part of it is figuring out what kind of neovaginal tissue is present. So most people in the United States have a penile inversion technique done where it's basically keratinized skin that's inside the vagina. But if you do have a patient that's had their neovagina constructed out of colon tissue, then that to me is a different animal, and I would definitely be screening that area. And then I think this is the last question I'm going to be able to take. What kind of fertility preservation counseling do you do prior to initiating hormone therapy as part of gender-affirming care? Oh, that's a great question. I mentioned pregnancy a little bit, and I talked about the impact of hormone therapy on fertility, but I didn't talk about fertility preservation for a couple of reasons. One is that a lot of it is outside my area of expertise in terms of the details of how to do it, and the second is because most of my patients cannot afford fertility preservation. But I agree, it is an important conversation to have around desired fertility and what the impact of hormones might be on future fertility options. The National Transgender Health Summit took place in April, and there was an amazing plenary speaker who talked through all of the data that was available on fertility and fertility preservation and what we know about the impact of hormones. And I think if you go to the website, you might be able to download the slides from the website or even email to request those slides to have a deep dive into that information. But yes, talking to our patients about fertility before starting hormone therapy is really important. Also, most of the people that I see who come to my practice have already started hormones in some way or other before I see them, either from another provider or from friends or the internet or somewhere else. So we have that conversation, but often the horse is out of the barn, as they say. Well, thank you for all these great questions. I want to move on now to sort of close us out for the webinar. It will be available for on-demand viewing and CME credits at the website that you see listed here. Evaluations will be available at 5 p.m. Pacific time today in your IAS-USA My Activities page. And for the final poll, if you get this one wrong, then you're asleep. When will the evaluation for this webinar, which you must complete in order to claim CME or other credits, be available on the My Activities page? Good. It looks like most of you stayed awake. Yes, it is 5 p.m. Pacific time today.